Hey, everybody, just a round of applause for the three co-chairs. Really amazing inaugural meeting, just out of the box, unbelievable. And thanks to our industry partners for really helping to make this go. So just my second disclosure, FOMO winner was Joe Abood, we know that. And I was the fear of missing my Columbia alumni dinner last night, so I actually missed the faculty dinner. So, but Joe still forgave me. So thanks, Joe. All right, here's my toolkit for success. And that's what I use in pretty much every cuff repair. Here's a 72-year-old patient, and she's got no arthritis, and she's got a cuff tear, and I'm gonna just go through this, and she has no significant atrophy. So we're gonna do a double row repair. And here are my steps for success. Patient positioning, B-chair position, of course. Make sure you take care of the cervical spine, especially in older patients. We do see problems from that. Make sure you have access, and I do all of this with regional anesthesia. We don't use general anesthesia. Portal placement's key, right? So we're going to use my three standard portals, posterior, mid-lateral. Sometimes we'll do two, an anterolateral and a posterolateral, depending upon the size of the tear and anterior. For the mid-lateral portal, this is really key when I'm teaching the residents and the fellows, because you can use your spinal needle to confirm the trajectory. Because now we're trying to decide, am I going to do a double row repair? Am I going to use some kind of augmentation? Am I going to do an acromioplasty? All of that's going to be key on where we actually make that portal. And then we just make our standard skin incision, put in our switching stick, dilate, and put in a cannula. So that's going to be really important to get things set up for the rest of the case. Debridement and footprint preparation. So this sounds like kind of, okay, well, that's boring, but this is the key part. We got to get rid of this stuff and have a healing surface for our rotator cuff. If we have all of these failures and we don't do what we can do from a biologic standpoint, we've probably hurt our patient. So we're going to take care to debride the footprint and do our subacromial decompression. What does that mean? We're going to do some bursectomy. Some people don't like to do a bursectomy, but I think from a visualization standpoint, it's really important. So this is the footprint preparation portion. This is the second key portion. If you're going to do a double row repair or you're going to use a biologic augmentation, at this stage, before you put anchors in and have sutures going all over the place, prepare your proximal tuberosity. You've got a time to do it now, and that's a really key point to do now and not worry later. All right, so now we got to identify the personality of the tear. If we think every tear goes from medial to lateral, we are wrong, and we're going to non-anatomically repair a rotator cuff. So is it a crescent tear that does just go from medial to lateral? Or is it an L tear where I have to understand where the transverse component goes, not just the vertical component, as we're showing on this shoulder? Or is it a reverse L where I got to bring that apex over to the anterior portion? Or is it a chronic UV where I might have to do some margin convergence? So if I don't understand the personality of the tear, it doesn't matter what technique I use, it's likely going to fail. And the technical pearls here are you want anatomic mobilization, you have to understand your tissue quality, then think about anchor placement and, of course, suture passage. So repair strategy. This is kind of my general algorithm. If it's a centimeter tear, I use a single row, 1 anchor repair, 2 centimeter single row, 2 anchors, greater than 2 centimeter, double row suture bridge, and then thinking about biologic augmentation depending upon revision status, poor tissue quality, or a high-grade partial tear. So anchor placement. I like to view from that mid-lateral portal so I can see exactly where we're going to put our anchors. It's really easy to do it this way, and you can see exactly where your anteromedial and posteromedial anchors are going to go. And when you're viewing from posterior, you're kind of guessing a little bit more. So this is just a nice pearl to make sure you can see exactly where you're putting your anchors. In this particular case, we're doing kind of a double row speed bridge type repair. So we're going to use a 475 millimeter anchor anterior medial, a 475 millimeter anchor posteromedial. And those are going to be our two standard anchors. Then suture passage is really critical. Whatever you do, just get a system that you're comfortable. So we know in my OR, we're going to take a blue ones and they're going to go anterior, and we're going to then pass the white ones posterior for this particular repair. So now we're coming in, we've taken the blues, we're going to pass that anteriorly around 12 to 14 millimeters, and we're going to park that suture out the anterior working cannula so that you don't have to worry about suture management. So everybody knows that we're going to always go blue, white. If you're using 4 sutures, blue, white, blue, white. And then we're going to take the white suture pair and we're going to pass that posteromedially. And so that's going to be the routine that I do in every single case. And so this is the way I like to do it, just again, so the residents and fellows and the nurse in the OR understands. So that's our way we do it. How to manage uncaptured cuff. This is just an important understanding. You take your cannula with your sutures for your double row suture bridge, you bring it over the side, and you see, you know what? I have some uncaptured posterior infraspinatus. So what's my challenge for that? Well, you can do this luggage tag stitch, and it's really a nice trick. You see where the posteromedial was. We take this looped fiber suture, and we go posterior to where our white suture came posteromedially, and just add that at the lateral aspect like a luggage tag. That's now going to be incorporated into my double row suture bridge technique. That's the posterior part. Same patient, we had a little anterior supraspinatus uncaptured, so there's an accessory suture on that fourth anchor, and we can just use the accessory suture, not have to add another anchor, more cost, and take care of the anterior suture. So now we go, here's your final repair. And you can see we've got a double row suture bridge. We have the posterior part completely covered, the anterior part completely covered, and I'm sorry I was 14 seconds over.
That was great, Bill. Sarah, what are your thoughts and what's your score first? What do you
Me? Did you
Sarah,
say
Sarah.
Sarah, I thought you said Jerry. You look like Sarah. I thought he said Jerry, okay?
Bill's always going to get a 10 from me. Okay. So he gets a 10.
But
You're going to see so much pandering on my
you
next
gotta ask him a question or give some commentary on it. You can't just give a score.
You know, I think the only critique I would have is that the video is a little shaky. It was probably...
All right, that's a point off
You called me
there, so it's a
producer.
9 out of 10.
So I'd say 9.5 out of 10 based on that.
Okay.
But otherwise, you know, in my talk, which is next, it's a lot of the same technique.
All right, Butch, what's the score and what's your comment?
So, thankfully, I do not have to pander to Bill, and I do know that I'll give you a score of content 10 out of 10. I mean, you went through everything so quickly, I thought I spoke fast. But, you know, I think I have to actually give you 11 out of 10 for your fashion statement. You were talking about bosom. Nobody can pull off wearing Dansko clogs with a suit or with casual clothing like Bill Levine can. I mean, that's amazing.
Jerry.
So, Bill's was always a 10 out of 10. That was a great talk. But I do have a question. It's a serious one. You're from New York. You're Columbia trained. Do you do acromioplasties?
Yeah, in the right patient, absolutely.
How often?
How often?
Give me a percentage. Full thickness cuff repairs. Chronic, not acute.
No, I'm looking for Nate and Tom. Where are our fellows? How often, Nate? Half the time. Okay. I didn't want to give a biased opinion. I thought they'd tell you the real story.
Well, I do way more than half the time, so I'm more biased than you.
So, follow-up question to that, Bill. When you do your acromioplasty, do you take the anterior acromion or the lateral acromion, or the inferior surface?
So I don't do it. Well, there are some patients, as you know, Butch, that actually do have a lateral acromial overhang that you worry about. And that may be someone that gets more classic McLaughlin lateral acromioplasty. But most patients, the pathology is anterior.
So you don't believe in changing the critical shoulder angle by taking the lateral edge?
I don't know enough. I don't know that we know enough about the CSA to make that call at this point.
So, Bill, I've said many times at this meeting, you know, what would Dr. Neer think? The acromioplasty has gone from the most commonly performed procedure in the United States of any kind to not being reimbursable by any insurance company.
Well, but remember, Jerry, if you look at Dr. Neer's original article, he presented on 50 patients who had and not all of them had acromioplasty. So, you know, I think that people overstate what Dr. Neer said. Dr. Neer looked at those patients that had severe anterior acromial spurs, and remember, it came at a time where people were doing radical acromionectomies, lateral acromionectomies, and they were hurting patients. So he went to the lab and he saw, hey, there's this thing on the anterior acromion. And he didn't say, oh my God, you have to do this on every single patient. So I think there's been some loss in translation.
But you can't do it on any patient now and get reimbursed.
Well, that is true. You can't get reimbursed.
Okay, that's it for the judges. Melissa, what do you think? Quick. What do you think? The microphone's right there.
About acromioplasty?
No, what's his score? What about Bill's talk? What score do you give him?
10 out of 10. Excellent.
Bill, I have two quick questions for you. Do you microfracture to the tuberosity to get the crimson duvet?
No, I'm not from Southern California.
Okay, I don't do it either, and I'm from Southern California. How do you assess tissue quality? You said poor tissue quality, you augment. How do you assess tissue quality?
So it's a good question. If you put a suture through with any of your devices and you start to see that you can just see the thing shredding through collagen, A, you might choose a different suture configuration, and B, that's when I might consider doing some augmentation.
That's what I do. I call it a spot test, suture pull-out test. So I pull on it to see if it stays or not. That's how I assess
We're
it.
going to steal that spot test.
Spot test. All right.